Hi, welcome to POC Nurse. My name is Gozi. In this video, we're going to talk about pulmonary embolism for the pulmonary section of the Ccrn exam. What's a pulmonary embolism, also known as a PE? It refers to obstruction, which may be partial or total, of the pulmonary arteries. Alright, and it could be caused by a thrombus or some other material. It could be caused by fat emboli. It could be caused by amniotic fluid embolus. It could be caused by air. Anything that obstructs the pulmonary arteries could cause a PE. So when these pulmonary arteries are obstructed, there's disruption of blood flow through the lungs. Now, a pulmonary embolism, a PE, could be massive or not. A massive PE happens where there is greater than 50% occlusion of the pulmonary arteries, and a submassive PE happens when there's less than 50% occlusion of the pulmonary arteries. Now, the most common cause of a PE are DVTs. 80 to 90% of PEs result from DVTs, right? For your Ccrn exam, you could most likely encounter a DVT or fat embolism as the cause of a PE. So this is when you get questions talking about patients that just had some kind of bone surgery, had some kind of orthopedic surgery. Maybe the patient had a fracture. Maybe the patient had a hip replacement or a knee replacement in your question. It is pushing you towards knowing that this patient may have shortness of breath due to a fat embolism. So we already said that a DVT puts patients at risk for developing pulmonary embolism. When I say DVT, I also mean VTE, venous thromboembolism. So what are the risk factors for patients having DVT or developing a DVT? So every time the patient comes into the hospital, at least in the United States, you have to screen that patient for risk of DVT so that you can properly intervene and try to prevent the patient from developing a DVT. So what are the strong risk factors for developing DVTs? A fracture of the hip or the leg, the lung bones, a hip or knee replacement, major trauma, or spinal cord injury. These will put a patient at a strong risk for developing a DVT. What are the moderate risk factors for developing a DVT? Knee surgery, having central venous lines, chemotherapy, respiratory failure, heart failure, hormone replacement therapy, cancer, taking contraceptives, a stroke. Pregnancy is a risk factor for developing DVTs. Being postpartum, that is after having a baby, a patient is at risk for developing a DVT. And having a previous DVT also puts a patient at moderate risk for developing another DVT. What are some weak risk factors for developing a DVT? Bed rest for more than 3 days, sitting down for a prolonged amount of time, increasing age, laparoscopic surgery, being obesity, being pregnant again, and the antepartum portion of being pregnant, that is before you have your baby, and varicose veins. So these are some risk factors for developing a DVT or VTE. Let's talk about signs and symptoms of PE. So we talked about a patient having a massive PE or a submassive PE. So the signs and symptoms are different because the way they affect the body is different. A patient with a massive PE will have hemodynamic changes that could lead to cardiac arrest. All right, so patients with submassive PEs, which will be most likely most PEs, patient's going to be short of breath, patient's going to be tachypnic, tachycardic, complain of chest pain. The patient may have right-sided S3 or S4 heart sound. This patient might be apprehensive, anxious, have a cough of blood, hemoptysis. When you listen to the patient's lungs, you might hear crackles, you might hear rales. The patient might syncopize, the patient might pass out. The patient might have petechiae due to fat emboli. Also, that's something to keep in mind. If they say this patient just had surgery and this patient is having petechiae, that patient might have a PE due to this fat emboli. All right, a low-grade fever and respiratory alkalosis are signs and symptoms of most PEs. Now, when we talk about massive PEs, we're going to have hemodynamic effects. Patient will be hypoxemic, that is the PaO2 will be less than 60 millimeters of mercury on the ABG. this patient's blood pressure is going to be low, the patient will be hypotensive. There will be changes on this patient's EKG. We'll have tall peaked P waves in lead 2 and the patient would have an ST elevation in lead V1 and V2. And finally, this patient could go into cardiopulmonary arrest and PEA. What are the types of PEs that we have? They depend on the cause. We could have a PE caused by a DVT, which is also a venous thromboembolism. We could have a PE that's caused by fat emboli that originates from the lung bones or due to pelvic fractures. We could have PEs that are caused by air emboli from IV lines or surgery. Patient might develop a PE because of having catheter embolization. Patient might have a PE due to AFib, that is a clot that originates from the heart itself and goes and blocks the pulmonary arteries. Amniotic fluid embolism could cause a PE, even though it is rare. It could occur due to a procedure called amniocentesis. Abruptio placenta, where the placenta separates from the uterus, or an abortion. So keep in mind, when you have a patient that's short of breath and this patient just had a procedure called an amniocentesis or abruptio placentae or an abortion, it may be due to an amniotic fluid embolism, even though this is quite rare. Patient might have a PE due to a tumor emboli originating from cancer, an increase in patient's thrombin levels, or the patient might have a septic emboli due to a bacterial or viral process. Now, how do we diagnose a PE? The gold standard for diagnosing PE is pulmonary angiography. Some other ways we could try to diagnose PE or other diagnostic tools for PE are a VQ scan, a CAT scan, blood work that could give you results on the patient's D-dimer. So if the patient's D-dimer is elevated, the patient may have a blood clot. And venous Dopplers, ultrasounds of the legs to see if the patient has a DVT in their leg, is also another diagnostic tool that we use to diagnose PE. Now, how do we prevent PE? Well, one way to prevent PE is to prevent the patient from developing a DVT. Remember, DVTs cause 80 to 90% of the PEs out there. So how do we prevent a patient from developing a DVT and therefore prevent the patient from developing a pulmonary embolism? Two ways: a mechanical way and a pharmacological way. The mechanical way involves putting compression socks on the patient, that is using your TED stockings. The other way is putting an intermittent compression device on the patient. That's your SCD boots. You put the SCD boots on the patient and you connect whatever machine that's going to squeeze the patient's leg intermittently so that they don't hopefully develop a DVT. Now, the SCDs can remain on the patient while they're in bed, and when they are walking, they can come off. Pharmacological ways of preventing a DVT is by giving the patient anticoagulation medications. So that is your heparin, your Lovenox, your Eliquis, and your Xarelto. How do we treat a PE? Well, the basic thing with the PE is that this patient might be hypoxemic, short of breath. There'll be respiratory symptoms. We want to give this patient oxygen, we want to ventilate them, and we want to make sure they have a patent airway. We want to give this patient fluids to improve cardiac output. We want to anticoagulate, give them the heparin, you want to give them the Lovenox, or whatever anticoagulation is available. We also want to give fibrinolytic therapy if there's an actual clot. That is if the patient qualifies. That is if it's appropriate for the patient. That is if this patient is at low risk for bleeding. If the patient has a hemorrhagic stroke, you would not want to give this patient a fibrinolytic therapy. We want to maintain cardiac output by giving the patient inotropes and of course fluids like we mentioned before. And if this patient is in pain, we want to give the patient analgesics. This is how we treat PEs. This is where we're going to stop for today. I hope that you find this video helpful. Please like, share, and subscribe, and I will see you in the next video. Bye-bye.